microphones will be muted during the presentation. And we'll, like I mentioned, get back to the questions and answer sessions at the end. To start, let me introduce our first speaker. We'll make sure that we have a presentation ready first. Share screen. Just a second, I think I will need presentations. Yeah, I'll press this one.
Thusego, I can share my screen if you like, because then I'll follow on.
Yeah, so that's great. That's great. Yeah, please do that.
Can people see my screen?
Yes, excellent. Thank you. Thank you. Yeah. I would like to start first with my colleague, Dr. Tendani Gaolatlhe. Dr. Gaolatlhe is the country director for the Botswana-Rutgers partnership. She's a lecturer at the University of Botswana, a specialist physician affiliated to Princess Marina Hospital. She's also a researcher affiliated to Botswana-Harvard partnership. Today we'll go up front and really look at preparing healthcare facility for COVID-19. And after her presentation, she will be joined by Dr. Lawrence, and I will introduce him when he starts his presentation. So, Dr. Gaolatlhe, please, the floor is yours.
Good day, and welcome once more. So what I'm basically going to do, I'm going to take you through the screening algorithm for COVID-19 at health facilities and services. I know we did post that we would be dealing with clinical guidelines, but a lot has been evolving and we thought this may be the right place to start. So can I have the first slide, please? So basically the guideline was developed by the technical faculty at UB and Botswana-Harvard partnership, and it really drew on guidance from multiple sources, particularly WHO. But we should acknowledge that actually we were also inspired by the Zambian guidelines. And this guideline has been approved by the Presidential Task Force and signed off by the Ministry of Health. But like all guidelines, and we know with COVID-19, it is rapidly evolving. So the guidelines are not set in stone and they will be responsive to new information and evidence as it comes out. But here really we'll share what happens and give a summary of the changes. Also, we do have a guideline on the clinical management of patients, which will be the focus for the next week's webinar. We do hope to have these webinars every Thursday on schedule. So to take you through the algorithm for screening at all health facilities and services. First, we are going to talk about screening. I'm just going to lay it out because Dr. David Lawrence is going to go in detail explaining all parts of the algorithm. So basically what it recommends is a screening questionnaire. And what we mean by a screening questionnaire. So basically this is at the first point of entry for all citizens, whether it be to a healthcare facility or not. Taking the example of Princess Marina, as soon as you come through the gate, there is a screening questionnaire that is administered to all who come through the gate. And if the screening questionnaire is positive and meets the case definition for a suspected case of COVID-19, pardon me, I'm not sure if it's projecting on your side. Yes.
It is. We are viewing it. Thanks.
Thank you. And a positive from the screening questionnaire sets you to the next point. If it's negative, it means that you do not meet the criteria for case definition of a suspected case, which will be discussed in detail. And a positive meets the case for a definition for a suspected case of COVID. And what would happen immediately? They would be isolated and triaged accordingly. And at the isolation point, they will be assessed. And if positive, the DHMT is notified. So basically what we're saying at all entry points, from screening, a positive test is referred to the DHMT for the next triage step. Next, David. From the DHMT perspective, after notification of a positive test and assessment, severity is determined, and it is graded mild or moderate to severe. For the mild, we look at the criteria as set out: O2 saturation greater than 95%, respiratory rate less than 25, at heart rate less than 120, at temperature from 36 to 39 degrees, normal mental status, age less than 50 with no other comorbidities, and are able to self-isolate. And for the moderate to severe, David? Sorry, and for the mild, if it meets all that criteria, patients are selected for isolation. And from isolation, isolation could be at a healthcare facility, it could be at home after initial assessment, and so forth. But really what we're saying here is that any patient with a positive screen, the determination lies with the DHMT, with the District Health Management Team. And the guidance on how they go about it will come up later. And from the DHMT perspective, for those with mild symptoms, and based on the recommendation for isolation, and by the time clients are isolated, they would have been offered testing. And based on the test result, whether it's negative or positive, it would guide the next step. For those with moderate to severe disease, these warrant hospital admission or isolation at designated areas where there is continuous health care. And the same applies. They do have positive signs and symptoms. They would be tested, and based on the test results, if it's negative, but you still have an ongoing suspicion for COVID-19, and there's no alternative diagnosis reached, they may be discharged. But if you do have suspicion, despite the test being negative, you may need further tests until an alternative diagnosis is excluded. And this, of course, will include repeating the tests. For those with moderate and severe disease and a positive test result, they will be transferred to a confirmed cohort, COVID-19 cohort area, and continue in hospital isolation and management. The DHMT is still notified, and they will be discharged from hospital once their symptoms and fever has resolved, and they are to remain in isolation for 14 days. And during that time, they will also be tested and discharged once negative. Next, David. So really, I'm going through this just to give you the layout for which David will discuss. But really, what are we trying to say? Things to think about. really what can health facilities currently do, even the DHMT, and is there anything they would need so that they could be helped out? And based on our facilities, because we all appreciate that they are different, how can we change our facilities to accommodate this new pandemic? And really, what resources would these facilities need? So I will have Dr. Lawrence continue, and after he finishes the detailed presentation, we will open the floor for questions. Thank you.
Thank you very much, Dr. Gaolatlhe. A quick, nice overview over the screening and testing, and also classifying patients from mild to severe, and how to deal with each scenario. We'll take a deeper dive now into the guidelines to take these things we have gone through now step by step and in more detail. And to go through that, I'm very honored to introduce our next speaker, who is Dr. David Lawrence. Dr. David Lawrence is a research physician who is employed by the London School of Hygiene and Tropical Medicine in the UK. He's a research physician who has been working on a trial called Ambition, which is a multi-site trial looking at novel approaches for treating HIV-associated cryptococcal meningitis. This trial is involving a lot of centers across Southern and Eastern Africa, and participants are being also recruited at Princess Marina. And Dr. Lawrence has been heavily involved lately in the development of these guidelines that we are presenting today. He has taken a break from his usual work at the IDCC as well, where he usually consults a patient. So please, Dr. Lawrence, the floor is yours.
Great, thank you very much for the introduction to Thusego, and also thanks Dr. G for the overview into the guideline. So this is very hot off the press. This guideline was only finalized yesterday. If you don't have a copy of it yet, we'll be sure to share it with you and make it freely available as soon as possible, along with the recording of this meeting. So before I go into the specifics of the guideline, I just want to have a note on terminology, because I think sometimes we see slightly different terms used across different guidelines, and that can cause a bit of confusion. I just want to clarify that the image on the left here of this slightly terrifying looking model depicts a surgical or a medical mask. That's a term that's used interchangeably. It's one of those pleated masks that you can see there. And the other type of mask is the one on the right, which is a respirator mask, which you might know as an N95 or an FFP2 or an FFP3. And it's important to know the difference between these two masks, because as the COVID epidemic unfolds, it will be very important for us to try and preserve those ones on the right, which is the respirator masks, because they're actually only recommended for treating individuals who are undergoing aerosolized procedures like intubation, bronchoscopy. So these are to be preserved for very specific scenarios, whereas the surgical and medical masks are indicated far more widely. And when we come to the PPE that's advised for each of the parts of this flowchart, then that will hopefully be helpful. So as Dr. G said, what we're advising is that anyone who is entering a healthcare facility should undergo screening. So that's all new admissions, all individuals who are coming for their outpatient appointments, all visitors once in a day, and then all staff as well need to be screened before entering any healthcare facilities. And for this to happen, there needs to be a well-ventilated outdoor area outside the facility, ideally shaded, and that provides enough space or with a plan that enables people to follow social distancing, which is maintaining 1 to 2 meters between individuals. And the person that does the screening at the front of the healthcare facility does not necessarily need to be a clinician. They just need to be a trained member of staff who has been well briefed on screening. And that individual needs to wear the following PPE, which is a surgical or medical mask and eye protection. So that's face shield or probably more available goggles. So that picture there depicts what that individual should be doing at the front of every healthcare facility. And then how the screening should go. This is an example of a screening form which we've produced and which we're making available to healthcare facilities. And we're advising that every individual then has to complete this screening form. And the screening form, as you can see just from down on the right, that outlines who that person is, if they're a patient, a visitor, or an employee. It's got their contact details on, so that then when it's held later at the end of the day, it's unique to that person on that day. And then it has a series of questions about travel outside of Botswana, travel within Botswana to an area where there has been transmission of COVID in the last 14 days, and any contact with a confirmed or probable case of COVID in the last 19 days. So there's those three questions to ascertain any if they've been in any locations where there's high risk for them acquiring COVID-19. Now, the middle one is an interesting one. This screening form is taken from the approved suspected case definition, how we're defining suspects in COVID-19. And at the moment, it's very difficult for us to really understand where community transmission is definitely happening. There's a likelihood that it's happening in areas without us having picked up on it yet. So just bear in mind that this form and a lot of these documents contain a case definition for a suspected case definition. But there's a very high likelihood that this will change because the risk factors are going to change. And actually that's what's so important about the second half of the form, which will become increasingly important if we do have widespread transmission, is about looking at any of these symptoms of what's called an acute respiratory illness. So there's lots of different symptoms of COVID-19. I'm sure you'll have heard of lots of them, but the four most predominant ones that make it into the suspected case definition are fever, cough, shortness of breath, and sore throat. So the idea is that every individual who approaches a healthcare facility will complete this form. And they will do that, and then that individual who's there will then review the form. If the form indicates that this person doesn't raise any suspicion then for being a possible case, then they will stamp that form, and then that person will be able to enter the healthcare facility. Those individuals are also going to have their temperature checked. So anyone who selects yes to one of those questions or has a temperature greater than or equal to 37.5, these people are going to be positive screens. They've gone through the process, they've answered the question, they've had the temperature, they're a positive screen. And they need to be given one of the surgical masks. And that's because if there is a chance they've got COVID-19, we don't want them to be at risk of passing that on to anyone else. So they're given a surgical or medical mask immediately. And then they need to move on to an isolation area for further assessment. Now there's negative screens, the ones that tick no, that have no symptoms, no risk factors. They should get their screening form stamped and dated. And that's their passport really to go into the hospital and move around the hospital on that day. And it may be that members of staff in the hospital will want to see that form to be confident that that patient or that visitor or that staff member even has had that form stamped. And what we really want to do is, we've seen a lot of forms being used at the moment and lots of pieces of paper, you know, people giving you pieces of paper to mark your number in the queue. We really don't want lots of unnecessary handling of forms, because we know, of course, that the virus can survive on paper, and that's one key way of it being transmitted from unnecessary handling of forms. So it's better for someone to fill in their form, then someone can look at it without touching it and then stamp it without touching it with their hands. And then that person can then show it to people without necessarily passing it over to them. So that's what happens at the screening. Now, the fact is that we've been doing this approach at the IDCC in Marina now for a couple of weeks. And the idea of that screening process, the purpose of it, is for it to be quick and efficient, and to be able to identify anyone who might be a suspected case, but then let lots of people through so that you can still actually have a functioning facility. So those individuals who do screen positive, that's not saying that they are definitely a suspected case. What needs to happen then is that someone needs to make a further, more in-depth assessment of that individual, which is going to involve things like asking them questions, digging a little bit deeper into their symptoms. Some people come into the clinic and say, oh, I've got a cough. Turns out they've had the same cough for a year. So, okay, we don't suspect that that's going to be COVID-19. It's not gotten any worse. But it's really only when you have a bit of time then to spend with that patient that you can figure out, do they truly meet this definition of a suspected case? So that's what should happen is after you've had that screening process where there's lots of people moving through, you have a dedicated isolation area for those individuals. And that should be somewhere that is separate to the screening area, but ideally quite close. We don't want people to be walking all the way through the hospital to get to this area where they're going to be isolated. And it needs to be a well-ventilated room and one that can be disinfected between use if you've identified a clinic room, for example. It may be outside under a shelter still. And then what needs to happen in that isolation area is then a trained healthcare worker, so this could be a nurse prescriber, or even a clinician, is then going to assess that individual to determine if they do meet that suspected case definition. So this is going to be taking a bit more of a history, more of a risk assessment, and really paying close attention to any other potential causes of fever. And then if they do meet the suspected case definition, okay, then you have a COVID suspect for sure. And what needs to happen is then the testing. And at the moment, that's organised through the DHMTs. So if at your healthcare facility you identify an individual who's a suspect, then you need to have within your facility a way of keeping a record of this, notifying someone senior perhaps, and then also a referral pathway for the DHMT to come and test. If after a bit of questioning it's quite clear they don't meet the suspected case definition, then of course they can have their piece of paper stamped and they can go. They're still allowed to enter the healthcare facility. So just to review again the suspected case definition, which is liable to change. So this is a patient with an acute respiratory illness, so that's sudden onset of at least one of the following: cough, sore throat, shortness of breath or fever, and a history of travel outside of Botswana or to an area in Botswana reporting community transmission of COVID during the 14 days prior to symptom onset. Or anyone with the same symptoms, an acute respiratory illness, who's been in contact with a confirmed or probable case. And then anyone who is hospitalized with those symptoms, but in the absence of any alternative diagnosis that fully explains their clinical presentation. And this is why it's very important to have not just at the gates where people who are walking come into the hospital, but to make sure that every single individual who is admitted through your A&E or into your hospital is also being screened. And as I said, just to say those case definitions may change as the situation evolves. In fact, they almost certainly will. So then this isolation and triage area, this is an area where you are dealing with people who are possibly going to be suspects. So this means that the PPE needs to be increased. This isn't just a screening on the outside where you're not coming into close contact with individuals. This is involving a bit of questioning and assessment. This is a dedicated area for isolation and triage, which means that the individuals who are involved in that work, the clinicians, the nurses, whoever's interacting with the patient, needs to wear the following PPE, which is a gown, gloves, eye protection, so goggles or face shield, and again, a surgical or a medical mask. And just to re-emphasize that those N95s, FFP2s, FFP3s, they are reserved for unique cases where individuals are undergoing aerosolized procedures. They are not required for this scenario. And of course, all of those other things we've been talking about apply: hand hygiene, social distancing. It may not be necessary to examine all of these people with a stethoscope, for example. And it's important to minimize the use of clinical equipment, disinfecting after use. If you're using a SATS probe and you're putting it on someone's finger, and we know that fingers are definitely one of the high-risk parts of the body that you could have the virus, then of course it's important to disinfect all of those after use. And just to recap then, so working on this idea that individuals need these 4 pieces of PPE, the order that they need to be put on is as follows. So after performing hand hygiene, the first step is to add the gown, then the mask, and the goggles or the face shield, and then finally the gloves. That's actually the easier one to remember. The thing that always gets a little bit confusing is about taking it off. And this is using the WHO's 2008 guidelines. These are still the same guidelines that they're referring to now with COVID. So this is tried and tested and established order. And they advise that if you're wearing those 4 pieces of PPE and you're treating an individual in a room, for example, that what you do is you simultaneously remove the gown and the gloves, then you clean your hands, then you remove the goggles or the face shield, then you clean your hands, with the idea being that every time you touch something, everything that you're touching could be infected. So every time you touch something, you clean your hands. You take off the next thing, you clean your hands. And then the last thing you should remove is the mask. And that should ideally be done when you're away from the patient. And so that might be when you've left the room or when you've then moved to a distance greater than 2 meters from the patient. And the thing, I'm seeing a lot of people in GABs with face masks, but they're spending a lot of time touching the front of the mask, which is exactly where the virus may be sitting. The idea is that you take the mask off from the back, you pull it off from the back. And then of course, after you've done everything, as I've said, hand hygiene is what you do. So that's just to clear up those points on PPE. So now we've talked about screening, we've talked about reaching the point where you're sure you've got a suspected case and you know that this person needs to be tested. So at the moment, as I said, all of that's going through DHMT, but this is likely to change. As things get, well, if things get more complex and we see more cases, we're likely to then be seeing clinicians and nurses also testing. So you'll either do the test yourself, and by test yourself, I mean you do it yourself, you don't do it to yourself. So test someone, or you call 997. And then those swabs are taken as a swab from the nose and from the back of the mouth. And they're sent then to one of the approved labs. So at the moment, that's Botswana, Harvard, and the National Health Lab. And they undergo real-time RT-PCR. But also we just have to bear in mind, and this is an important point, is that the sensitivity of these tests is not 100%, it's about 70 or 80. So you will expect false negatives when you send tests. And actually one thing that we've learned is that it's quite common that you may see radiological changes, so chest X-ray changes, CT changes, before the test is positive. So those are just a few of the caveats about testing. Now, when we talk next week about the clinical management of patients, I'm going to go into more detail or collect this sample. But given that this is currently just being done by DHMT and not done widely, I think in the interest of time, we're going to move past this. But I'll just point out that we do have within our clinical guideline, we've got guidance on how to do the test. We've also got this poster as well. So we're hoping that we'll see these posters appearing on a hospital or clinic wall near you soon. So we will go into that in detail another time. It's just that would maybe distract from the process that we're talking about now. And then one of the key things then when you sat with someone who's a suspected case is to make an assessment of, is this person sick or are they not sick? So do they need to be admitted to hospital, or are they okay to not be in a hospital but to be somewhere else? Now, everyone who's a suspected case, we're assuming at the moment that they have COVID-19, so they all need to be isolated. The question is really, how do you decide where that is? So that's about determining if someone is a mild or a severe case. So mild cases may be managed outside of hospitals, in isolation facilities, or even possibly at home. But that very much depends upon the individual district and the latest guidance from the ministry. Those cases that are triaged as either being moderate or severe need to be admitted to hospital. And of course, we all know that some people can get more sick. Outpatients can become inpatients. So we just need to bear that in mind. But this is really important for all healthcare facilities because you need to determine, are we going to be able to admit suspects? If we are, where are we going to put them? And so that's really key. And so this is our criteria for the definition of mild disease. And this has been based on the WHO and the South African guidance. Now, some of this guidance is evolving over time. It's likely that our criteria will change. This is probably the most conservative criteria at the moment, which means that it's likely that very few people or fewer people will meet this criteria for now. But as things change, if they change, we may broaden this criteria depending on what we learn from those people with mild disease. So this is the criteria. Dr. G also talked through them earlier. It's about having SATs that are greater than or equal to 95%. All of these must apply. A respiratory rate less than 25, heart rate less than 120, temperature essentially less than 39, a normal mental status, and an ability to self-isolate. So this really depends on what the isolation facility available is. If it's for someone to be isolated at home, well, you need to assess if that's even feasible within their homestead. If it's that they're able to self-isolate in a hotel, for example, then of course that may be easier. So we'll have to see about what's available at each individual district. And then we know that some individuals are at high risk of deterioration. And so for the moment, we're saying anyone greater than 50 years of age and with any significant comorbidity. So that's cardiac comorbidities, pulmonary comorbidities, cancer, things like that. At the moment, there's no evidence to suggest that well-controlled HIV is an independent risk factor or a prognostic indicator an indicator of severity for COVID. So we're not saying that HIV that's well-controlled needs to be on that list. And as I said, these things will change. It used to be in South Africa that they also said age greater than 50. They've now moved to 60. WHO says 65. This may change as things evolve. For now, whilst we have the capacity, or as we have the capacity, I think it's okay to be a bit more conservative, and then we'll see and we'll learn from what happens with our cases. So if someone doesn't meet those criteria, then they are automatically meet this definition of being a severe case, a moderate or a severe case. And those individuals need to be admitted to a healthcare facility. So each individual healthcare facility needs to determine if they have the infrastructure and capacity to admit suspected cases of COVID-19. And that needs to be based for just general care and also for those very severe cases that need intensive care and intubation. And each facility needs to determine if they've got the capacity to do that now or what they would need to be able to do that. And I believe that there will be some communication from the ministry regarding completing healthcare readiness assessments at each facility. And obviously, if a facility doesn't have the capacity for inpatients, then they need to establish at the district level, well, where will I send those people then? Those people that I screen, who are a suspect, who I think have moderate or severe disease. It needs to be quite clear where they're planning to go. And then it needs to be reciprocal that the facility also knows that they would be accepting those patients. And then the same applies for when someone moves from level 2 to level 3 to intensive care. Well, do you have the facility to that, for that, the capacity for that, or don't you? And therefore you need to know where you would refer those ones to also. And I mean, one of the key aspects of having the infrastructure to admit patients with COVID is that the mainstay of treatment is oxygen. So having a reliable oxygen supply is going to be one of those key parts of that assessment. Now, what will happen is when someone is admitted with suspected COVID, you're then going to have to wait about 2 days before you actually get the test back. So these people will all be ideally in a side room, but possibly in a ward together, depending on the numbers. And at some point, it's very likely that some of those individuals will then get positive tests. And what needs to happen is those that have a positive test need to move into a separate area. So a separate room or a separate ward, depending on the facility, that quite clearly is for those who have confirmed COVID. Because there is a possibility that some of these suspects don't have coronavirus. So therefore it's important to, once you know someone has coronavirus, to isolate them in a separate cohort. So for now, these patients are all being managed at Sir Ketumile Teaching Hospital at University of Botswana. And that's the referral pathway for sick patients with confirmed COVID. But the chances are that the situation could change, particularly given the size of the country. And so that's just something for all facilities to bear in mind. Where would you put patients with confirmed COVID? If you had 1, where would you put them? If you had 4, where would you put them? If you had 10, where would you put them? And that's really key in the planning for the healthcare facilities. So then after this, then of course, there comes questions of discharge when patients get better. And we have this criteria for discharge from hospital, which I think you'll all find is fairly reasonable. I'm not sure if any of you would discharge anyone from hospital if they didn't meet this criteria, which is that the fever must have resolved, the symptoms are improving, and there's no other indication for admission. And then we've made the decision, which is also quite conservative, that after discharge, patients should remain isolated for a further 14 days, regardless of the length of their admission. Now, it is likely that that guidance may change depending on our experience with the first few patients, but for now, that's the guidance as it stands. And then, of course, there's also the suspected cases. So if you have a suspect who tests negative, and if you still suspect that they have coronavirus, of course, you're bearing that in mind. The sensitivity of the test is 70 to 80%. So there will be some patients who do have COVID-19 but have a negative test. So the suspected cases, you may deem it necessary to retest them based upon your ongoing suspicion that they have COVID. Or you may think, actually, no, I found out they've got TB, or I found out they have PCP or something else that is going to maybe say, okay, I'm very confident that they don't. And then, so they would remain a suspected case. Their test comes back negative, but of course, then maybe they get better, you want to discharge them. That's based again on these same criteria: fever resolved, symptoms improving, and no other indication for admission. Now, all of those patients are to remain isolated for a further 14 days after admission, regardless of the length of their admission. And that's in cases where they have been cohorted together with other suspects, because there's a likelihood, if they've been treated with other suspects, that even if they don't have coronavirus now, they are likely to be a contact of COVID-19, and therefore they need to remain isolated for 14 days. I think that covers everything that's mentioned in the guideline. I haven't added much more to this talk that isn't already written in that guideline, so I do hope that you'll have the chance to go and read that and review that. And this is just a summary then of that diagram and what we've talked about. So screening at the front door, isolation and triage of those who screen positive on the questionnaire, and then testing of those individuals who then are deemed to be true suspects. And then a severity assessment that then determines if those patients are managed outside of a hospital ward or in a hospital ward, and then what to do with discharge. So that concludes everything that I was hoping to discuss today. So I'll pass over to questions. Thanks very much.
Thank you very much, Dr. Lawrence, for a very in-depth discussion and thorough, detailed assessment of everything from screening up to testing, and also doing assessment of the disease severity up to practicality surrounding discharge. Thank you very much for that. There's been a lot of questions that have been coming in as the presentation went on. Thanks to some of my colleagues in the panel, some of those questions have been answered as time went on. And like I mentioned earlier, there have been a lot of questions that came in before today's webinar. But we could see that most of those questions were clarifications regarding what really has been prepared today. So we hope that a lot of those questions were answered through the presentations itself. And then other questions actually were more related to logistical issues, more operational. So we hope that a representative from the Ministry of Health will be able to help us with that. So let's see if there are other questions relating to what we've just been going through here. I think there was I saw one question that asked if it's okay to not have protective wear on the feet when doing PPE. David, do you have any comment on that? So
the current guidance for for foot covers is actually only applies to cleaners at the moment, as covered by the WHO PPE guidance. So the guidance that we've got for healthcare workers who aren't involved in cleaning is, of course, we would prefer everyone to wear closed-toed shoes that they can clean themselves rather than being at risk of spills, but the shoe covers which are likely to be in short supply are reserved for the cleaners themselves.
Thank you, David.
Are you going to accept comments, Honorable Chair?
Yes, please.
Yes, so thank you everybody for Dr. Tendani and Dr. Lawrence. Thank you for the presentation. On the last slide of Dr. Tendani, my little worry is the DHMT bit. Because as it is now, I hope that the Ministry of Health official will really tell us where they are, because we are really getting into trouble. I'm afraid that we're just going to be caught off guard. By the time we are running around to prepare, the cases are coming, and then we wouldn't know what to do with that. So I hope there's what I expect is that there must be a minimum package that every facility in the DHMTs should have. Not to say what can we do with what we have now, or what other things do we need. What is it? We have to have a standardized package that every DHMT should have, and then we work with the DHMT based on what they have, improve that given standard, so that at least by the time the cases are coming, we know exactly how to handle that, and we have the facility in place to do that. And I really don't know where we are now. I'm trying to ask the case, have we made the facility assessment as at now? Because we really don't have that time. We don't have that time to really get, not to have been prepared before we start getting these cases through. So this is my initial comment. Thank you.
Thank you very much, Doctor. That concern is registered.
Okay, I also have a question.
But maybe first, before your question, can you please mute?
Sorry?
Yes. Yeah, hello. Yes, my comment was that the doctor's comment is registered, and we are hoping that the representative from the Ministry of Health will also comment on that part. Yeah, and she should be coming in very soon. So I'll introduce her when it's time to present.
Okay, so hello.
Yes.
Hello.
Hello.
Can I go ahead and ask? Okay, I'm Dr. Nkoma. Just in Dr. Lawrence's presentation, the patient who is being discharged, is there a need for retesting before discharge for now, seeing that in our situation we don't have so much kits? And then also, I think there's been a very interesting term that is being used in other countries that have had a much more mature epidemic than ours. The term recovered. Would you like to talk to those two?
So in terms of retesting, the only stipulation for retesting that's currently in the guidelines is for a suspect who tests negative, whom there's still ongoing suspicion that they may have COVID-19. In terms of the discharge, there's no current recommendations for a test of cure or for repeat testing before anyone is discharged or de-isolated. And that's based on the fact that, as you've said, there's limited access to testing, and it's unlikely to be feasible to do that in the context of a widespread outbreak. And then can you repeat the second question? So I'm not sure I fully followed that one.
I think the interesting, in the reports that you see globally, you see recovered. I've been trying to, it's not an important term, but I think it's important to understand, of course, you will have recovered clinically, but what does it mean in terms of actually the actual monitoring, otherwise, in terms of the tests? since now people are understanding the antibodies that are, these people have.
Yes, I'm not sure myself of the exact definition of recovered for each individual country. It may be that some of them are dependent on having repeat tests that are negative, and others it may just be based upon resolution of symptoms or discharge from hospital.
Can I make another comment or ask a question actually?
Thank you very much, David, for that clarification. I would actually right now like to take this opportunity to introduce our third speaker, who will also help us on another on Ministry of Health related issues regarding handling COVID-19. It is Dr. Rankgoane-Pono, who is coming from the Ministry of Health, who will share with us updates from the ministry. Dr. Rankgoane-Pono is a public health physician and a deputy incident manager for Emergency Operations Center. So please, Dr. Rankgoane-Pono, the floor is yours.
Thank you very much, Dr. Lawrence. I will do my quick presentation and then try and address the questions that were answered regarding practices by the Ministry of Health. So what we know now is globally, there are about 1.46 million cases and about just more than 85,000 deaths. This is from the Johns Hopkins. Am I audible?
Yes.
Okay. All right, so this is from the Johns Hopkins website. If you look at the WHO website, the WHO website is not very up to date in terms of the number of cases. They're usually a day late. So the most up to date will be the Johns Hopkins website. So these numbers are from that website. Next. Please, next slide. Okay, so in Africa, 52 countries have reported cases. The number of cases, total number of cases is just more than 10,000 with about 492 deaths and 989 recoveries. Next. So for Botswana, currently we have confirmed COVID-19 cases. We have 13 cases. The age range, we have 2 between 25 and 34. 4 are between the ages 35 to 44. 2 are between the ages 45 to 54, and 1 55 to 64. Out of those, we have 1 death. Sorry, so 25 to 34, we have 3 cases. We have 6 cases between the ages of 35 to 44, which is the majority of the cases, and then 2 and 1, 55 to 64, and 1 death, which is a female between the ages of 75 to 84. So most of all our cases, how many are? 6. Local. Okay. So out of the 13, 10 are imported cases and 3 are local cases. So somebody earlier on was asking about local transmission and community transmission. So the difference between the two with community transmission is you have a chain of transmission patterns, but you can't really locate which one, some of them, most of them, majority of the transmission chains, you can't locate where they are from. So there's transmission in the community, but you can't really locate where the transmission is from. So currently we have local cases, but all our local cases, we can connect each case to an index case. So we don't yet have local transmission in that, or community transmission in that regard, but we are getting there as the cases are increasing. So these are the updates that I have from the country, but I also wanted to just maybe touch on the questions that were asked. According to the case management guideline of the World Health Organization, there should be retesting done for cases that were confirmed positive before discharge. And that's what we are currently doing in Botswana. And therefore, that's how also you define recovery. Those who are recovered are those who tested positive at the beginning, and then before discharge, they obviously with the recovery, looking at symptoms and also the test, they test negative. So that's how you define recovery. And also in Botswana, we're also doing retesting in that regard. In terms of preparedness, Dr. Jibril asked concerning preparedness. I'm hoping I'm not talking to politicians, I'm talking to healthcare workers who know the system also in Botswana. There was an assessment, initial assessment that was done of isolation centers with the districts, and most of the districts said they were ready, but we realized that districts were not ready when they were getting suspected cases, because they were then saying, no, our isolation centers are not ready, even sending mild cases to hospital. So one of the priorities of now the Emergency Operations Center is ensuring that isolation centers are ready and they're prepared, so that districts are able to handle cases, and maybe just severe cases that probably need intensive care or high care can be sent to hospital. So I'll be here, but waiting to address questions if there are any.
Can I just come in, sorry, on that comment about retesting? So I just want to outline further that at the moment, the currently approved guidelines on both this guideline we've discussed and also the clinical management guideline that was approved last Friday, both of those guidelines outline that we are not doing repeat testing for test of cure or looking for negative tests in individuals that are admitted. And that's in line with actually what most countries are doing. They're using, as is being commented on the group chat, a clinical definition for recovered, and they're not doing PCR testing at discharge. And that's actually what currently is stated in the approved guidelines.
Hello? Hello?
Hello? Hello. Hello again, sir. Let me first thank the doctor from the Ministry of Health for clarification and also update on number of cases. We still have a number of questions that were actually directed to her. So I'll let my colleague, Dr. Belonyana, go through some of those.
Good afternoon, everybody. We received a lot of questions from yourselves. As you know, when we're registering, we requested that maybe you give us some questions. So some of the questions are going to be addressed in the next webinars. As you realize, today we had a specific one. Most of your questions, of course, you were asking about the PPE that has been addressed today, but there are a few that maybe Ministry of Health as an overall we might need to respond to. Some of your questions were about the readiness. So this questions actually will guide us to the next, what topics we should take next. And you ask quite a number of questions about the disease characteristics that you also will be addressed, the treatment and care, the lab, multi-sectoral, meaning that the private sectors are here, the NGOs are also here. They want to know their role into this. But now coming to today's topic, I think David has addressed most of the questions, and some I realize people like George Avis were answering, but maybe to the ministry, there have been overall questions like what measures are being taken to ensure that we have adequate PPE in place, looking that globally, they're actually in high demand. So these are some of the questions that they're putting in place, they are being asked. And another question that maybe what PPE is needed for community health workers at a community level. I think it has been addressed somehow. It can be emphasized. But also there's a question about wearing of masks by the general public. I think people are looking now that some other countries are starting to recommend. So what is the stance for Botswana? So this is questions regarding PPE, maybe that I can say, maybe the Minister of Health can look at. I'm not going to bring in the other questions that the topic are still coming. But maybe the other ones that maybe while I'm still on stage, that maybe Minister of Health, we might need to say something, is go to the private sector because they're here. They're asking, how can the private sector best assist the Minister of Health in the response of the management as early as now? Maybe we might need to bring them in. And what is the role of the NGOs in the COVID-19? They want to know how can they help as early as now. So also that we bring them in. And so those are some of the questions that they want us to engage them. We, in the presence, we have people from private hospitals, we have people from private clinics and all. So really, as we address all of us. Thank you.
Thank you very much, Dr. Lebelonyan. So currently, there is a serious shortage of PPE all over the world. What the ministry has now, it's enough for now, but we can't say it's enough for next month. So the ministry doesn't provide PPE for the private sector. What we do is through our supplies office, we give the private sector a list of suppliers for PPE, and then they can order directly from those suppliers. What is also the ministry is doing in preparation, we are working on getting PPE from China. We have been mobilizing suppliers in China and getting a cargo flight to go and get PPE directly from China for the Ministry of Health. So that is the bigger picture and the bigger plan.
Hello.
Yeah.
Thank you, Doctor, for that clarification. Dr. Jibril, please pose in a question.
Yes, so for me, really, what is critically important to us is we should have one guideline that we use. From the presentation, I'm getting confused. There is an approved and signed off guideline which was presented. Then from the ministry, they say they are using the WHO guideline, especially in the tests before or during recovery. So for me, really, it's critically important to have one guideline streamlined for all practitioners in Botswana to use. We cannot afford to have two different versions of that we need to have. That's my comment. Thank you.
Yeah, Dr. Jibril, that is noted. We will talk after this.
Thank you. I can see that there have been more questions coming in, which have been addressed by the other members of the panel, which is good.
So there's a question on how effective is self-isolation, who's monitoring that someone is on self-isolation. So currently, the essence of self-isolation, of self-quarantine, I hope people know the difference. So maybe just to say, self-quarantine is done on people without symptoms. Isolation is done on people with symptoms. So if you have symptoms and you are at home, managed at home, you're on self-isolation. If you have no symptoms and you are managed at home, you're on home quarantine. So self-isolation is really dependent on having community structures that will do monitoring, making sure that people are where they're supposed to be. They're not where they're not supposed to be. And currently we do have a challenge in terms of the number of community healthcare workers, even the number of nurses that can do monitoring for those on self-quarantine or self-isolation. So we are working with our partners, PEPFAR partners, to expand this cadre where we'll have people who are on the ground in the community and monitoring those who are on self-isolation and self-quarantine. I think it's one of the reasons why then the ministry took a decision to do mandatory facility quarantine for all travelers coming into Botswana.
I have a question as well to Dr. Pono, Mr. Chair.
Yes, Dr. Tafela.
Please go ahead.
Yes, yeah, now God forbid, we don't go into the next stage, which is, community transmission. But for better preparedness, if these things start to happen, how prepared are we, and what is the magnitude of, our anticipation, and preparedness, to go large scale contact tracing, which is very key now if we move on into the next stage.
Okay, thank you, Dr. Tef. So we will have community transmission very soon. There is no God forbid. And we are working, we have the national contact tracing team and we have district contact tracing teams. But like I said, there's still a shortage here and there of, in terms of numbers of people who are able to do contact tracing. And it's one of the things that I said, we are working with our PEPFAR partners to avail community healthcare workers and nurses who will be capacitating on strengthening the contact tracing teams in the districts to do more contact tracing.
I think, Goaba, there's also one question on the plan for assessing facility readiness.
Okay, so we do have a WHO template for assessing country readiness, including facility readiness. We've done reviews with the districts using that the checklist or that template to assess the readiness. But like I said, one of the things that we are aware, and it's one of the priorities now for the ministry, is healthcare workers' capacity in terms of how to handle cases, in terms of, some of it might be anxiety for them to say the isolation center is not ready, but anxiety also speaks to the knowledge that you have. So that's healthcare worker capacity, that's isolation centers, that's the lab, and also contact tracing. So these are the 4 priorities currently for the EOC, for the Ministry of Health, that we are working on strengthening.
Thank you very much, Doctor. I can see that we. Oh, Dr. Malo, did you have a, oh, okay. I can see that we are now working beyond our planned time. We're supposed to finish in an hour. But of course, we appreciate all the questions that are coming in. We're getting more clarifications on a lot of things. But we won't be able to answer all the questions today, because like we mentioned when we started, this is just the beginning. This is our first webinar, we are sensitive to all the questions that are coming in, and it will help us actually define the need out there, and also to help us make suggestions on topics for future discussions. So there will be more webinars coming in, hopefully addressing also other questions that maybe some of you feel are not completely answered yet. So I'll open for maybe just one last burning question before we wrap up. A question: if can we get access to the presentation?
Exactly.
Yes, you will get access to this presentation. We are finalizing the website for Corona. I hope today or tomorrow we should be ready and live. So we'll put all the presentations, all the forms, tools that we are using as the Ministry of Health, and any other information. So this will be the platform for information for Corona.
May I just... Hello.
Hello.
Yeah.
I was just thanking you.
Thanks for the presentations. Just one quick question as we're talking, planning, and bringing in other health workers. Have we mapped out how many people we need and where, just so that we are targeting the right people to bring into the response, as opposed to getting too many bodies on the ground and then stepping on each other's toes when we should be working in a more structured manner? So that's for the ministry to help us next time. This is the plan that we think that we have for manning this response. When we reach these levels, we need so many people, and this is what we're looking at doing. Because that way then all the partners know how best they might fit into the response and when they might be needed, as opposed to rushing in when we aren't too sure where we are best placed to assist, more so as private sector and NGOs come on board.
Okay. So one, there's what we do with the districts is they present their needs. They write down their needs and then present that to the Ministry of Health. One, and then secondly, the partners, the PEPFAR partners are part of our Public Health Emergency Management Committee. So they are aware, they attend meetings with us, they are aware of the needs of the ministry, and therefore they proposals that are based on the needs of the ministry, the proposed needs of the ministry. I don't know if that answers you, Dr. Pologol. But the situation is very fluid. So what we need today is not what we will need tomorrow. So we continually look at our work plan and you know, look at our gaps and also address them as and when there's a need.
Good job.
Thank you very much. It's very good to have a representative from the ministry to, you know, help us with these other issues. Well, let me take this opportunity to thank all of you for availing your precious time to be a part of this webinar. We have registered that 150 of you were online. That is very commendable. We hope that the numbers will keep on increasing as the webinars also keep on coming. To close, I would like to remind you that when we leave the meeting, there will be a survey, a short survey that we request you to fill so that it can actually help us evaluate today's webinar, see what you think worked well and what you think we can improve on. And also, it will also help us find define topics for future discussions. So thank you all for attending, and stay safe.
Thank you, Dr. Laura.
and happy Easter.
The Piqua person, can they call me on 3632206 now? Somebody who said there's no PPE in Piqua, which is very strange. Please call me now on 3632206.
Repeat the number again.
3632206. Don't flood me with calls, just the Piqua person.
Thank you.
Thank you.
Thank you, Mr. Chair.
Bye-bye.
Okay,
Yes.
Thank you. Thank you.